tobacco is another really good example. Like George Washington grew tobacco. Tobacco is one of these things that was like embedded in the culture of some of our countries going back hundreds and thousands of years. Yet we managed to change the social norms around smoking and cigarettes quite dramatically. And I think the other thing that's really helpful is to compare between us as countries, because I think that can be really eye-opening.
Hello and welcome to the Clinical Changemakers podcast. My name is Dr. Jono. Thank you so much for being here. Today on the show we have Dr. Nason Maani. He is a lecturer in Inequalities and Global Health Policy at the University of Edinburgh and an expert in the field of Commercial Determinants of Health. Dr. Nason Maani, welcome to the podcast.
Hi, Jono. Thanks very much for having me.
Now, I'm really excited to get into your area of expertise around the commercial determinants of health. But before we do, I'd wondered if we could maybe step back and understand what are the determinants of health and how does that kind of flow into this idea of the commercial determinants of health?
Yeah, of course. So I suppose a way to think of determinants of health is as those wider forces around us that shape health at the population level, often in unequal ways. So if we think about health and kind of broader efforts to improve health as being like a football team, then, the clinical care is the goalkeeper. That's that you want a good goalkeeper for when health outcomes are poor and you need treatment on recovery. You want a good goalkeeper for that last ditch effort. But a lot of what shapes health are these forces way outside the clinic, way far away from doctors and nurses and hospitals. It's things like education, housing, air quality, social norms, right? Like home environments, access to money. These are the things that are like these other players on the field. And because they determine health to a large degree, they're sometimes referred to as the wider determinants of health. And unfortunately, often when we engage in conversations around health, we're really talking about healthcare, like the goalkeeper. And while that's super important, I guess the concept of the wider determinants of health and why they matter is clearly a big part of that conversation.
And I know that I think you grew up in Northern Ireland, if I'm not mistaken, and I've heard you talk about how in Northern Ireland some of the surgeons became, expert goalkeepers, you could say, in reconstructive knee surgery, and were able to perhaps go to conferences all over the world to explain these incredible techniques that they developed. But when you looked at upstream of what was happening, I'll maybe let you kind of finish that story.
It's a story that really reminds me of that core question of like what it is that we're really trying to achieve in health. So as you say, there were these kind of really wonderful surgeons who became experts in reconstructive knee surgery in Northern Ireland, and that's because it was kind of a common practice for kind of vigilante justice among paramilitary groups, where they would, abduct people from their places of work or housing if they'd been suspected of collusion with security forces or some other crime, and then they would shoot them in the kneecap and then drop them off at the emergency room. So there's a high frequency of these kind of devastating knee injuries, and surgeons, as you say, became really good at reconstructive knee surgery and pioneering techniques, and sort of went around the world sharing these techniques and getting prizes and that kind of thing. And in a way, that's a story of success in medicine, of like innovation. But when these kind of patients when their care was complete, when their knee had been reconstructed, where did they get sent? They get sent right back into the workplace or the living room that they'd been taken from, and back into the communities that were still just as violent as they were beforehand. And the other element to that is that there was a very strong gradient in terms of social inequality. So the people who tended to be in the areas that were interface areas with high levels of violence, high levels of unemployment, also tended to be areas of very low education, high deprivation. So that was kind of a lot of those patients were from that background. The people who tended to be surgeons who were doing that work, lived in kind of largely, not exclusively, but largely leafy suburbs in Belfast, where people were much less likely to care or ask which side of the fence you were on, and that kind of thing. So there was this like duality, right? There was like sort of an inequality in terms of who's got agency and who's solving the problem and how that problem's being defined. And you have this kind of inequality in the sense that you have this narrative of success, and it is a success in a clinical sense, but this wider narrative of like social failure, right? Like a failing to address the causes of these injuries in the first place. And I guess that's an example of like upstream drivers that matter for health.
It's such a powerful example, and I'm going to try to connect that up with some other phenomenon that happen, now in other societies around particular surgeries like amputations for someone who's got really bad diabetes, and other types of operations due to some of these chronic diseases that are manifesting this social determinants of health and inequality. And many might look at those examples and see them on such vast extremes, but I think they are actually encapsulated in the same sort of problem set. It's just that the drivers in those scenarios are just different types of levers at different types of times. Taking that into the world of commercial determinants of health, how do these how does that field interrelate with these the social determinants and the football team that we're talking about?
If we think about these kind of wider determinants of health, these wider forces that shape health, right, that are out there in society, there has been, an effort, I would say, over the last few decades to conceptualize these and to kind of get more coherence in terms of policy action on these. So World Health Organization, health in all policies, you see in countries like New Zealand, the idea of like a well-being budget or economy, like moving kind of beyond thinking about health as being something that requires input from all of society. But there's an aspect of these wider forces that really has kind of been lacking from that kind of consideration in the same way. And that's the fact that a lot of these environments are actually shaped quite powerfully by commercial forces. That's particularly the case in modern society, in part because you have like globally consolidated, very powerful commercial actors who can shape the food environments that you're navigating, but can also shape the working conditions, the availability of medications, the regulations around them, regulations around pollution, right, or climate change. And you have, I guess, a much more digital and interconnected world. So that power can manifest in a lot more different ways. So the commercial determinants of health has emerged as a concept to try and acknowledge and bear witness to these wider forces and to address them. And I think most clinicians would recognize the uniquely damaging role the tobacco industry has played, right, on population health, on preventable deaths. And that's a really good example of where commercial actors intersect with health inequalities and social inequality, because what was originally constrained to a number of high income countries and originally predominantly a male pastime, through commercial influence and the expansion of commercial actors, shifted just from men into women increasingly through targeted marketing and product design, from high income countries through to low and middle income countries, right? Through expansion and buying up of like local resources and supply chains. And that's an example of a really huge, dramatic determinant of health that now overwhelmingly affects those who are least well off in terms of developing countries, and in high income countries, lower income groups, that is largely commercially driven. And that's kind of one of a range of other examples where that is the case. And that's why it makes sense, if we're thinking about the kind of wider determinants of health and how they link to social inequality and health inequalities, it's important that we think about commercial drivers as part of that.
And the tobacco industry is almost sort of the poster boy for a lot of the tactics and sort of behaviours that other industries have sort of picked up, particularly around influencing research and lobbying. I wondered if you could maybe illustrate a couple of examples or of those types of tactics that might surprise many of us that are being reflected across a number of these industries.
Yeah, I mean, I think the first thing to understand is that there is nothing uniquely evil or malign, I would say, and that's controversial to say, about the motivations of people who worked in the tobacco industry. They were just people, and people working in jobs, going home and, kissing their kids and putting them through college and all that kind of thing. By and large, they were just people doing jobs. Problem arose because of the fundamental conflict between profit and population health. And that was particularly extreme in the case of the tobacco industry. And the internal documents show this, that it wasn't they were uniquely evil. They were motivated by profit. And a big part of that is protecting your future revenue, right? Preventing regulation and maximizing positive PR, because all those things are linked together. If you start to get negative PR, that increases the risk that you might get sued, it increases the risk you might get regulated. So if you've got a product that's really, really damaging, then it's a case of you either get out of that. But if you can't get out of that, these companies chose to kind of double down and influence all those other levers, right? And that there's nothing unique about that. Um, uh, because there's nothing unique about those kind of incentives. We can think of lots of different companies that might have similar incentives. And so, just to give some examples, sugar sweetened beverages is a really good example. So, it's an example where you have particularly high consumption among certain groups, particularly strong associations with obesity, with diabetes, which you mentioned before. And you have a really consolidated sector where you got a couple of big conglomerates that control a big global share of the market. So similarly to tobacco, what has been found through research and through leaks of internal documents and freedom of information requests is that these companies tried to fund research on physical activity. So to distract from the impact of sugar sweetened beverages on obesity by sort of funding physical activities researchers to say it's all about physical activity. We need to get kids more active. That's what the problem is. Funded a lot of research on sort of like the complexity around the drivers of diabetes and obesity. Funded a lot of corporate social responsibility efforts around getting kids active, sports programs, this kind of thing. And what has emerged is that this was all a kind of a coordinated effort to prevent things like sugar taxes, which might dramatically reduce sugar consumption in teens, but might also lead to what internal documents described as a global threat to our business. That's an example that I think is all around us. Like you probably come across Coca-Cola funding some physical activity program and not giving it a second thought. Just thought, that's great, somebody's funding that. But when you put it in this wider picture, you see, oh, they're funding this because it fits together with a wider strategy that prevents them being regulated, even though that might be in the best interest of population health.
Learning about that is fascinating. It's like it feels particularly pernicious to be funding charity organizations. The alcohol industry does it as well, that have great names and a great website if you go on there and out, doing community activities. But when you look at the language, when you look at the things that they aren't saying, you can see with a critical eye that I think you've given me more of, to identify those gaps and be more aware. I also wanted to pick up on the idea that often when we think about these organizations, the way that we imagine their view of us is actually different to how they look at us. The fact that they will have super users of certain products that might take up 10 or 20% of their users and be a extremely valuable user. And I know that certain alcohol companies have even had internal documents that have said, the damage that would be done if super users were to become a middle of the range user. So just to kind of highlight that I think when we imagine how they perceive us, it's quite different to how they're looking at their market and how they're looking at probably growing their market.
Yeah, absolutely. And I think that's something that's, again, going back to the links between social inequality and kind of, I guess, the upstream drivers of health problems. I think that this is something that plays quite powerfully into this. So if you are one of that 80%, like you mentioned, of people who maybe kind of quite rarely consume alcohol or consume it at quite low levels, you might be quite tempted to think that, yeah, I mean, it's all about individual responsibility. And, this company say they want to encourage responsible consumption. People like me, I agree with that. I'm doing fine. It's quite like a compelling message, and it distracts from exactly what you said, that, behind the scenes, that 20% that consume at very high levels, they account for like 70 to 80% of the whole market. So from the industry's perspective, they're like the golden goose. And part of saying it's all about individual responsibilities kind of distract from the fact that they are the golden goose. They don't want them to go away, and they don't want anyone to interfere with that golden goose. The last thing they want is for us to focus on regulatory policy that dramatically affects them. So it's much easier to say it's all about individual responsibility and implicitly saying these people are broken in some way. They're irresponsible. So it also has this kind of stigmatizing aspect to it as well. And I think that's kind of particularly pernicious.
That othering of other human beings, your neighbor, your cousin, someone you went to school with, what have you. That's pretty brutal, really. I wanted to pick up on some of the comments you made around the research space. Coming into this conversation as a clinician, I've read papers before and done bits and pieces in those spaces. And so when I hear you say things like, "Oh, well, they're writing this research about exercise or what have you," before getting involved in these topics, I would have thought, well, you just that's a bad journal that nobody listens to, or that is a piece of work that's probably put on a shelf somewhere. But my understanding is it is actually a lot more powerful because of the way that it shifts the questions that are being asked, and it kind of floods the zone of nutrition or whatever research with a whole lot of this stuff that can be very good in a technical sense, but perhaps asking questions that shift the focus. I wondered if you could pick up on that.
Yeah, and I think in medicine we have to be particularly mindful of this, because it's not just a case that, well, as long as we have these academic papers and they acknowledge conflicts of interest in the kind of footnotes, then that means we can acknowledge any biases and we can accept the findings. And that's kind of normal, particularly in trials sponsored by the pharmaceutical industry, for example, right? You might have a lot of investigators and a lead investigator who are clinicians as well, and there might be some people from the pharmaceutical industry, and all the conflicts are acknowledged in the paper, and that's fine. But in reality, like you say, part of what that funding can do is really shape the questions that are being asked. And over time, even like what's considered relevant expertise or what's considered relevant scientific disciplines to consider a particular topic. So, to give an example, you can have an institute that's set up to deal with the issue of chronic stress or migraines. Like that, I'm going to set up Jono's Institute for chronic stress and migraines, and you want to put together an interdisciplinary team. You want people who are social workers and social scientists who are dealing with what are the environmental stressors that are driving this, right? People in employment who are dealing with employment law, and people who are dealing with like sort of physical environment stressors, clinicians, and you also want people who are thinking about the genetic drivers of this and, potential treatments. You start this institute, but what you'll find is over time, the people who approach you who want to fund research, but there's almost no one interested in funding the kind of social drivers of migraine and stress. There's very few people interested in funding the kind of the work-based drivers of migraine. There are, however, a huge amount of funders who want to approach you about co-developing potential migraine treatments or pain meds. And what you find is over 10, 20, 30 years, the kind of departments at your big institute, which had these kind of initially this kind of very broad base, parts of them have atrophied and died away. And actually, you're no longer an institute that's centrally interested in preventing stress and migraine. You're a migraine treatment institute, and all of your research is about comparing, novel pharmaceutical compounds to treat migraine. But it's worth remembering that what caused kind of stress and headaches in the first place, what caused migraine in the first place, was not a lack of migraine treatments. That's not what caused, you know what I mean? Like, your headache is not caused by a lack of aspirin. Your headache is caused by something else. And so the questions that you would want to ask about that, they're much broader than that. The question's not which pill can I take? The question is also what's driving that more widely. Do you know what I mean? And thinking about, well, are there regulatory approaches that could reduce the amount of environmental stressors? Are there, alternative ways of town planning or of organizing? That's an example of the kind of pernicious nature of that bias, that it can be quite gentle but very powerful, particularly over time. And going back to the example of sugar sweetened beverages, it goes from who do we invite in the room to talk about obesity being, well, let's talk to public health researchers who are studying the environmental drivers of obesity, to let's invite physical activity researchers. And it just so happens that some of them have also been funded by a sugar sweetened beverage company. It sort of changes the nature of the question.
I could see how where you're going with this then sort of starts drifting into that policy space, because you can imagine a new government or what have you wanting to address one of these types of issues. And so you go to the migraine treatment experts, right? And, there's nothing wrong with being that kind of researcher. But if you're shifting that window of really good questions, I think I can hear how that just really narrows the possibilities for solutions, and it means we're missing out on a whole area of research. But when you do take things up to that policy level, what are the tactics or what are the efforts that maybe commercial actors might be playing? People like to throw around the word lobbying, and lobbying means different things to different people. It depends on what they're lobbying for, essentially. And also for some of us, I'm putting my hand up here. Imagine a dark room, everyone's wearing a cape, and maybe there's some lightning somewhere or something, and people are conspiring, but it's actually not quite as dramatic as that. I wondered if you could talk to what the kind of lobbying policy development space is usually like in these areas.
The first thing to say is that it's quite opaque. So there is an element of that sort of dark room, not literally, but it's often very hard to trace as a researcher. So a lot of lobbying will be through just interpersonal relationships and meetings over drinks, or at a sponsored event, or even in people's homes, like dinners and things like this. To differing degrees, countries have lobbying registers where lobbyists have to kind of be listed and interactions with policymakers have to be noted, but that varies dramatically country to country. And again, it often is over reliant on written records. If a lobbying letter has been sent to a group of members of parliament, then that would be recorded in such a lobbying register. So the first thing to say is that there's a lot of it that's just simply not known. The other thing is to say that, as you said, lobbying is not something that's exclusively practiced by these kind of shady, dark money organizations. It's something that, a lot of charities engage in lobbying, a lot of NGOs, advocates, are lobbying all the time. I guess some of the ways in which lobbying, particularly by what you might call unhealthy commodity manufacturers, like these kind of the ones that we're talking about, can be particularly powerful, is that they're often speaking to different parts of government at the same time. And they are often speaking with a voice that's not just their own voice, but they're speaking through trade associations, like wider business associations, not just individual companies. And they're also speaking through kind of coalitions of other groups, like the alcohol industry might also be speaking through groups of retailers or hospitality sector, or advertisers, because there's quite a close link between them and advertising associations. And because of that, that lobbying can be really powerful, because it can seem like a wave of opposition to a particular initiative or policy. They can also kind of lean a bit on this idea that you're not letting us into this room, but other parts of government let us in. We get really good connections in the Ministry of Finance, or we really get good connections in the Home Office or Trade, and we do a bunch of work with them on trafficking or on modern slavery. You should let us in the room to talk about this health policy. So these kind of connections can be really powerful. And the third thing is that lobbying is just one part of these kind of wider strategies. And so what they can do is leverage a lot of other work that's happening. They can leverage their knowledge of investments in employee schemes, or their knowledge of corporate social responsibility efforts that are happening in parallel. So they can go to someone and say, well, we're doing these community initiatives over here, and we've put this much investment into there, and these economists are saying this will be the harm if you proceed with this policy. And again, they create this kind of bigger, like quite comprehensive looking picture of opposition or of evidence. And the reality is that they've kind of strategically seeded that, or they funded that in part to help with this lobbying effort. So those all make it kind of really compelling for policymakers who are often a little bit risk averse about these things, particularly when thinking about potential economic costs. I think the final thing to note, and that's been the learning from Scotland in particular, is that there is no punishment for producing quite misleading figures about that, if you know what I mean. So like there was a bunch of figures produced about how minimum unit pricing in Scotland would like devastate the sector, devastate hospitality, devastate the alcohol industry, that were produced and used by industry to say, look, this is going to be really damaging if you go ahead with this. The government did go ahead with it, and none of that really came to pass at all. The industry is growing year on year, but there's no real punishment for that, if that makes sense. It's not like if you're a scientist and you produce these figures in a journal and then it got retracted, that'd be really damaging to your career. But this is a bit more of a political game where it's sort of a little bit what you can get away with.
Yeah, I mean, it sounds like they are able to play with a different set of rules to the game that we're playing. It speaks to that idea of sometimes these huge organizations have this personhood about them where they have these protections on their activities that supersede the needs of a population of people. And there's legislative protections and all of those sorts of things, so that power imbalance is so immense at times can feel really difficult to know how you actually change any of that.
No, I agree. And I think as difficult as it can be, I think it's really important to remember that it is changeable and that we have examples of where environments have changed quite profoundly. Like there was a time when asbestos was really commonly used in buildings and in brake materials. There was a time when lead was widely used. And believe it or not, in each of those cases, there was an industry that fought back against it. There's still an asbestos industry that funds lawyers to oppose claims for asbestos related illness and to try and make sure that in those few applications where asbestos is still being used, that their use is maximized, that regulations minimized. A, there was always this opposition to these kind of things, but B, pretty significant positive changes were made over time. Tobacco is another really good example. Like George Washington grew tobacco. Tobacco is one of these things that was like embedded in the culture of some of our countries going back hundreds and thousands of years. Yet we managed to change the social norms around smoking and cigarettes quite dramatically. And I think the other thing that's really helpful is to compare between us as countries, because I think that can be really eye-opening. When I hear some of the arguments made around, you'll never change alcohol harm in this country, and maybe, Australia and New Zealand, maybe there's similar ideas that, we're just a hard drinking culture and that's just who we are, and you're not going to change that. Well, setting aside the fact that you've got this 2080 divide, right, where it's not that everyone's drinking the same. That is so similar to the arguments I heard in the US around firearms. Firearms have always been a big part of our culture. That's not going to change. It's really complex, and no one factor will change it. And politically, just nothing's ever going to happen. But For example, in Australia, we know that, fire action on firearms happened relatively quickly and had an instant effect on eliminating school shootings and mass shootings instantly. But the kind of arguments around the complexity, the nuance, the culture around firearms in the US, they continue to this day. And the firearm industry, they do educational programs in schools for children about what to do if you find a gun. They have corporate social responsibility programs, and they sort of dispute public health expertise around firearms, and it's not a public health crisis, and then it's all very complicated. It's about individual responsibility, it's about responsible gun ownership. And when you start to compare, you can see, gosh, we're being taken for fools a little bit here. Like, this is very very similar to the kind of rhetoric being used in my country about a separate thing. So hopefully there's hope there. I think when we look at examples from other countries where they've been really successful in one area or another, we can see that, yeah, these kind of lobbying groups can be quite powerful. These health problems can be massive. So firearms are the leading cause of death among children and young people in the US, more than traffic accidents, which is just incredible to think about, right? But that can change. Alcohol is one of, if not the leading cause of death among children and young people in our countries, through accidents, through injury, violence, because children, young people don't die from many other things. Yeah, we could probably do something about that.
When you were speaking then, I was thinking of this concept called punctuated equilibrium, where basically it seems like nothing happens until suddenly it does. And we don't always know what is the snowflake that falls on the mountain to create the avalanche. Which one was it, that one, or was it 10 before or 10 after? And so people working in those research and advocacy type areas, that momentum is often more silent until it isn't. And something changes in sort of cultural norms and acceptance that shift the needle in quite profound ways. As you say, many of our histories are intertwined with some of these types of activities, and we've actually shown an immense amount of resilience and courage and hard work to shake them off. I wanted to talk about doctors and healthcare professionals and what our role is in this game, because in some sense we could say, well, we're just goalkeepers, I just need better gloves and better boots. But what role do we have in improving these sorts of spaces?
For your listeners who play football, you'll know that the goalkeeper does a lot more than just saving goals, because the goalkeeper has a really clear view of the whole field and actually spends a lot of time screaming at their defenders to keep the ball away from them. You know, go there, because otherwise they're going to have a shot on goal, right? Go there, move the wall this way, because I can't cover the whole goal by myself. And if you ever watch a football game, you'll see the goalkeeper constantly gesticulating, constantly screaming. And I think in healthcare, our voice can be particularly powerful, because the public, as far as the public's concerned, doctors and nurses are the custodians of health. They're the kind of experts of health, and their voice carries a lot of weight. They're very, very trusted, much more than politicians are. And so we shouldn't underestimate the power of that voice, when instead of screaming for, look, I just need better goalkeeping gloves, or I need better goalkeeping shoes, which is really not going to cut it. That's definitely not going to cut it, as nice as that would be. But to say, look, I can't keep treating people just to send them back into the conditions that made them sick. You need to make those conditions better. There's no amount of social prescribing I can do that will overcome a fundamental lack of more affordable housing. You know what I mean? Like, there's no amount of treatment for gastrointestinal diseases I can prescribe that will overcome a really broken water system or sewage system. Does that make sense? Like, it's about using that voice to kind of lending it to advocates or to community groups or to people who are pushing for those kind of things, because that can be really, really powerful. And I'm going to paraphrase, but there's that really famous Martin Luther King quote that true compassion is not about tossing a coin to a beggar. It's understanding that an edifice that produces beggars requires restructuring. Like that's what true compassion is. And I think in the same way, true medicine is not just kind of tossing a treatment to someone who's very sick and sending them back out there. It's understanding that a society that produces this many sick people, this many preventably sick people, requires restructuring. And if you're a primary care physician and you've maybe been working in, for example, a low income area, you don't need me to tell you that your patients have, multiple concurrent morbidities, have very little opportunity to adhere to the treatment regimens you do prescribe, have very little agency to change the amount of hours they work, the amount of responsibilities they have for caring for children, the fact that they might be a single parent. They have very little agency over those things. So even if you only care about treatment and adherence, you have to accept that all these other forces, right, like this wider structure, requires recalibrating if ultimately we want people to, you know, stay healthy, and when they do get sick, have a good chance of getting healthy again.
That's really powerful words, and I really like that. I think it certainly makes me reflect on my own practice and actually some of my own sort of education and training. Going through medicine, and basically it really hit me once I started practicing. Working on the pediatric ward and holding on to some kids to not send them home because we knew their home wasn't safe, and we would involve various other colleagues to support that discharge. But then seeing that kid back again in a week's time, and I think in kids it's even more obvious how much lack of agency and choice that they have. So I think those are really powerful words to take away. So I guess thinking about this field, I wonder what is kind of on the forefront of this field? What are the things that are exciting you, or perhaps are helping us to get more and better types of insights into the commercial determinants of health?
It's a really good question. I think I'm definitely going to give an answer which is incomplete, which is a good thing. I think there are lots of different things happening at the local, national, and international level. So I think one really positive trend has been the increasing interest among the World Health Organization and similar type organizations, health agencies around the commercial determinants of health, and trying to look beyond kind of tobacco exceptionalism and see that actually a lot of preventable harms are encompassed here around, for example, air quality related deaths, or around obesity related deaths, or alcohol related deaths. And that's a really positive starting point. And that has at times translated into, toolkits for better governance, for managing decisions better. It's turned into guidance for managing conflicts of interest better. So in interactions with these kind of sectors, like making sure that policymakers, particularly when we're dealing with health policymakers, have a clearer understanding. The World Health Organization has published things like a guide for health reporters on alcohol, so that health reporters who are writing articles for the public on alcohol harms have an understanding of the role of the alcohol industry, the conflicts of interest there, some of the common themes and tropes they'll use around individual responsibility, and like some evidence about that, to help them kind of shift some of the norms around that. So I think these are examples of really powerful things. The other potentially powerful things, the other thing that I think has been really interesting is to see an increase in scholarship and appreciation for the unique challenges faced in low and middle income countries. So the fact that, in high income countries, we might be really focused on something like tobacco or alcohol, but in some low middle income countries, actually, they have those problems potentially, but some of the biggest drivers of health might be related to the fact that they're part of the supply chain for big companies located elsewhere. So really big problems around occupational health for garment workers, or people who work on banana plantations and these kind of things, for the health of people near or related to extractive industries like mining or oil. These are really, really big health problems that might be much less visible or salient to health policymakers in the West, but are incredibly important drivers, commercial drivers of health inequalities in low middle income countries. And I think the final thing that's been really exciting and that I've been very privileged to be part of here in the UK is an increase in interest among funders. And that's included trying to identify solutions around this. So, like, what are our governance tools? What kind of actions can we take at the local level? So, because at times national governments maybe not that interested in this kind of thing, but you might have particular regional or local authorities who do have an interest because they have an acute need. And so there's been the launch of a recent research theme led by Professor Anna Gilmore at Bath, funded by UKRI, UK Research and Innovation here in the UK, entitled Local Health Global Profits. And it's really about finding levers at local authority level to help address some elements of the commercial determinants of health, and be that through how we think about procurement at the local level, how we think about health inequalities, how we think about partnerships. Yeah, there are some examples of where really interesting work is underway, but I would caveat that by saying there's still a lot more to be done, particularly in telling this story to the public and to clinicians, to people like your audience, in a way that they see themselves as protagonists in it.
I think that's a really interesting point. It's kind of like translating that research into, I don't want to say the kinds of marketing material that these groups use because we want this to be, factual and all that good stuff. But I think you're right. And I think in clinical medicine and academia and these sorts of spaces, we can be so disconnected from, busy people paying rent, going to work, just doing all the good stuff, and how we actually communicate this stuff in the real world. There's another piece to this around, some of these products might make us feel like we're hypocrites, or that we can't stand up for some of these types of things because maybe we have an electric car, and that battery had to come from somewhere, and all of those kinds of things. How do you think we reconcile that sometimes internal discomfort with not being perfect in how we interact with these types of things?
That's really powerful. I think that's referred to sometimes as the hypocrite's trap. This idea that, well, I can't do anything because, to some degree, I personally have done something that's inconsistent with this kind of wider goal that I'm advocating for. And I think that's also a problem when it comes to building social movements more generally, where there's a tension between wanting to be inclusive and making the movement as powerful and broad as possible, and this tension for like kind of purity, and sort of being like, well, you're not as committed to this as I am, or you're not as extreme as I am. And I think that's a really problematic tension, because ultimately, with a caveat like what's worked in tobacco, because ultimately tobacco industry is still very profitable, very lucrative, still present in many, many parts of the world, in all parts of the world. But what worked to shift the needle on tobacco was really broad coalitions, really united fronts across advocacy, public health, clinical medicine, members of the public, people harmed, people who were grieving because relatives and friends of theirs had lost their lives to tobacco and lung cancer. That's the way we have to think. It's about building that base and making it as broad as possible, rather than self-exclusion because, well, I drive an electric car, or because I enjoy a drink like a couple of times a week, or more than that. I mean, in fact, what's fascinating to me is speaking to members of the public. So I've done some work with NCD Alliance here in Scotland around communicating to the public on these issues, and they have public panels, and you present to them, and then they reflect what they think back. And these panels are sort of representative. So they include people from like different backgrounds, sort of retirees, students, people from affluent parts and deprived parts of Scotland. And what's really fascinating is that they get it way more than clinicians do in some ways, because they face these things in a lot more of an acute way. Like, they see power imbalances, they see conflicts of interest in some ways way more starkly, and they're way angrier about it. Even if you just explain to them the differences in life expectancy between poor and wealthy parts of the city they live in, and what some of the key drivers of that are, or if you explain to them the inverse care law, they are way, way angrier about that than we are in academia and medicine. I think those things can be really powerful. And I've heard people who have experience of really acute alcohol harm sit back and say, I can't believe how much money those companies took from me. When I think back to, I had a huge shelf, at the top in my kitchen, on the very top shelf, I had a huge shelf of all these drinks. I remember one lady saying, when I think back to all the money that was represented in that wall, all the money that they took from me over all those years, it kind of makes me sick, you know, that I had this problem. It was my problem that I had it, but that at the same time, they were taking so much money from me. I think rather than sort of worrying about the challenges of communicating to that wider audience, I think actually that's where fertile ground is.
I guess my last question, maybe bringing a few of these threads together, was a comment that you made earlier around this idea of health in every policy. It's a really interesting one when you draw the determinants of health in with policies that are made and think about them through a health lens. And it doesn't have to be a no fun lens. It can just be, what are the implications for the health of people in these types of policies. So is that the kind of the understanding of this type of thinking, or what does it look like to have health in every policy?
Yeah, so the WHO has produced these kind of health and all policies frameworks and guides. And I guess the core idea is that since almost all policies affect health and health inequalities, that health should be an explicit consideration and almost like a performance metric. The theory of that versus the practice of that is very, very different and difficult because governments are siloed into departments. They're led by political appointees who have very conflicting goals and motivations. I mean, at times we have to deal with a much more acute problem that whoever the head of our health service might be, the political head of our health service, their kind of life's ambition might not be to improve population health, it might be to be prime minister one day. If that makes sense. And those are two very different goals. The same is true of the head of the treasury. Their goal might not be to leave public finances in the most perfect way. Their goal might be to be prime minister next. So that's one level of challenge with health and health policies, that you got really competing interests between departments. Then you got competing interests over timescales, right? Like acute versus longer term. The principle, I think, is really fundamentally sound, which is that the only way to improve health over the long term, when you consider how much of health is generated by these wider forces, right? The only way to improve health and to ensure the sustainability of your healthcare system is to at least acknowledge the trade-offs for health in all policies. Now, if you end up saying, because of our beliefs, because of our social values, because of the economic costs of doing this particular thing, we're not going to do it, even though it might improve health, at least acknowledging health in that trade-off makes it more transparent and hopefully less damaging. Austerity is a really good example of that. Like I think now, 2 decades later almost, there is a really broad consensus that some aspects of austerity policies in the wake of the financial crisis dramatically affected life expectancy, particularly in low-income areas, particularly among women, affected things like birth weight and preterm births, affected substance abuse dramatically, particularly in countries like Scotland, particularly in the lowest income groups. And that's because drug treatment services, social support services, social housing, these are all things that were encompassed in the cuts. Health was ring fenced, health was protected, but it was a really powerful example of there were these critical health trade-offs involved in these decisions that weren't really considered or acknowledged at the time. And it's almost like a terrible natural experiment of, it's not enough to protect the goalkeeper. You know what I mean? Like if you protect the goalkeeper and cut everything else, guess what? Health's going to get worse. And the goalkeeper's going to be far less happy. I don't think there's many clinicians who prefer practicing today, particularly general practitioners who prefer practicing today than they did pre-austerity.
Well, I think that's a great note to end on. I just wanted to do a massive shout out to your podcast called Money, Power, Health, which I've listened to all the way through now twice because it's that good. And also your book called The Commercial Determinants of Health, another fantastic read. Nason Maani, thank you so much for being here on the podcast.
It's my pleasure, John. Thanks so much.
And that brings us to the end of the podcast. If you want to go deeper about any of these topics or join in on the discussion, visit our website clinicalchangemakers.com or our YouTube channel. Finally, if you enjoyed our work, please give us a rating and share your favourite episode with a friend or colleague. Until next time, take care.